Now, in addition to kidney, so much about the basic structure of the kidney and basic functions. We have two ureters, remember, coming out from the kidney, about 30 centimeter long. These are muscular tubes, and they will pass obliquely through posterior aspect of urinary bladder. There is peristaltic activity. So every few minutes, you will have a peristaltic wave which will push the urine downwards into the urinary bladder. Okay, this last point I will explain in the picture. It will be easier to understand. Okay, bladder is a reservoir. Again, the wall has a muscle which is known as detrusor muscle. Okay, urethra is the outer tube which will help in excreting the urine out of the body. Okay, it has different lengths in females and in males. Now, if you look at this, this is urinary bladder cut open from the front to show you what is inside. The ureters open into the bladder from the posterior aspect, and the way they open, they pass through the bladder wall obliquely at an angle, and then they empty into the bladder. The benefit of this entering through an angle is that when bladder contracts in order to empty the urine through the urethra, it collapses the ureteric opening, so urine cannot go back. This is the urethra, the opening into the urethra. Okay, and urethra has internal sphincter which is autonomic, automatically controlled, and then you have muscles around the internal sphincter which are called external sphincter, skeletal muscles which are under conscious control. Okay, now what is micturition reflex? Micturition reflex is whenever kidneys are making urine all the time, and urine is slowly dribbling into the bladder. Bladder keeps filling up. Okay, a time comes when there is enough stretch on the walls of the bladder that stretch receptors get stimulated. They will send signal to the spinal cord, all right, and then an immediate response will come. This is a local reflex. At the same time, you have reflexes coming from the pons where you have micturition center in the pons. This is through parasympathetic nerve fibers. And once the bladder is filled until to a certain capacity, this pontine micturition center will initiate the micturition reflex. This is involuntary reflex. This is not in our control. Okay, usually when bladder is about 400 ml filled with the urine, this reflex is initiated. Okay, this reflex, what it will do, it will cause the muscle in the wall of bladder to contract with force, and it will allow internal sphincter to relax, so micturition can take place. But at the same time, there are signals coming from the higher centers that control external sphincter. So if the condition is not socially appropriate, the reflex will be, the parasympathetic reflex will be suppressed, and external sphincter will not relax. Micturition will not take place. Does that make sense? So there are two components of this reflex, involuntary and voluntary. In infants, they don't have the voluntary component yet, so whenever the bladder fills, it just empties itself, right? But when they grow, they develop the voluntary component of the micturition reflex. Let's look at the processes around urine formation now. Now, the first thing that happens, this is again a schematic diagram. Blood is over here and kidneys are over here. Okay, imagine this is the filtration barrier. So whatever passes through the filtration barrier will pass through the renal tubules. Then you reabsorb a lot of things that are needed by the body. And there are certain things which you don't need. They were filtered, but not completely. Then you secrete them forcefully. Okay, so these three processes will end up in the formation of urine. First thing is filtration. Filtration is generally non-specific. Anything small in size will filter, okay, whether good or bad. So filtration is very non-specific. Remember, after the glomerulus, the glomerular capillaries, what hafpened? The efferent arteriole came out right? And it was then passing along the tubules. So first the filtration happens, then the arteriole passes along the tubule. When it's passing along the tubule, all these reabsorption and secretion will take place. And at the end, in the collecting duct, you have the final urine produced after all the reabsorption and secretion has taken place. Does that make sense? Okay, so after these three processes, urine is formed, which is then excreted from the body. Simple. So filtration is non-specific. A lot of filth is produced. Remember how much was the cardiac, how much blood was flowing through the kidney? About 1 liter per minute, right? Large amount. Okay, so immediately water is reabsorbed, sodium is reabsorbed, glucose is reabsorbed, all the good things that you need back. Okay, and it keeps passing. Certain acids that we don't need, they are excreted, they are secreted into the tubules. More reabsorption, secretion, ultimately you have urine which is excreted. Okay, so three processes for urine formation. So what does nephron do? It filters plasma first of all, then it reabsorbs and secretes. It forms a filtrate which is essentially protein free, so no proteins or amino acids. It regulates the composition of the filtrate to maintain blood volume, to maintain concentration of electrolytes in the body, and also pH. Let's look at more detail now on filtration, glomerular filtration. The amount of filtrate which is produced in the kidney each minute, this is known as glomerular filtration rate, or GFR. GFR. It is 125 milliliters per minute. Okay. The factors that alter filtration pressure will alter the GFR. What is happening at the Bowman's membrane or the filtration membrane, there are many forces which are forcing the water out. There are certain forces which are trying to keep the water in the blood. Now if you look at this is the glomerulus, the blood inside the capillaries. In the capillaries there is pressure, hydrostatic pressure or blood pressure, which is causing the fluid to leave the capillaries. There is some pressure, there is some fluid which is present over here. So there is some pressure of fluid which is opposing the water from coming out. But the force which is causing the water to leave is much stronger than the force outside. So the pressure in the capillary is much more than the pressure in Bowman's space. So water will go out. All right. At the same time, within the capillaries, you have proteins, mainly albumin. You know, one of the feature of albumin or proteins is that they keep water, right? They are water loving. They keep water with themselves. So this force, the presence of proteins, it opposes filtration because it is trying to keep the water in the blood vessels. The hydrostatic force or the blood pressure is forcing the water out. Generally, if you look at the forces here, this force is about 50 millimeters of mercury, the capillary hydrostatic pressure. Okay, the hydrostatic pressure in the capsule is about 10 millimeters of mercury. So what is the net pressure here? 40 millimeters of mercury is pushing the water out. Then you have oncotic hydrostatic pressure. So the proteins in the capillaries trying to keep the water in the capillaries, again 10 millimeters of mercury. So how much is the net pressure here which is forcing the water out? Is 30 millimeters of mercury. Okay, this 10 is opposing, this 10 is also opposing, but this 50 is trying to push the water out of the capillaries. So minus 10, about 30 millimeters of mercury is the net filtration pressure that is forcing the water out. Why these values are important? Because if you remember, kidneys are receiving large amount of blood flow. There are millions of nephrons. If you change this pressure by 1 millimeter of mercury in each nephron, you can imagine how much difference it will make on the total amount of filtrate produced. Huge amount of difference. Okay, so these values, although they look very small, but little bit of change in these values will lead to a huge change in the amount of filtrate that is produced at the filtration barrier. Does that make sense? Okay. And this is where, remember, the auto-regulation comes into play as well. Each nephron regulates its own blood flow and everything. All right, so some interesting facts. A GFR of 125 milliliter per minute is equal to 7.5 liters per hour or 180 liters per day. So if you do not reabsorb anything from the tubules, how much urine you'll make every day? 180 liters. Because this is the amount of filtrate produced by the kidney in 24 hours, 180 liters. The normal urine volume is about 1 liter per day, which means 99% of the filtrate gets reabsorbed in the tubules. So reabsorption is a very big factor in the whole process of urine formation. And if you look here, 60 times the plasma volume in a day. So every day, the whole blood in our body passes through the kidneys 60 times. So this is how much blood flow is there to the kidney. So kidneys can effectively remove all the waste materials from the blood. Now GFR is very important and we should have some method to measure it. And it gives you a good clue about kidney health. Okay, how do you measure GFR? You can measure, GFR is just the filtration, right? There's no reabsorption involved in this one, no secretion. So we need a substance which is only filtered at the filtration membrane. It doesn't get reabsorbed, it doesn't get secreted. If we have such substance, we can use that to measure GFR. So inulin is a plant origin polysaccharide not normally found in our body, but if you inject inulin into a person, this substance only gets filtered. Nothing else happens to it when it is passing through the tubules. So by measuring the amount you injected into the patient and the amount that comes out in the urine, you can measure filtration. So it is given intravenously and then you measure its amount in plasma and the amount in urine, and there's a formula that you can use to calculate GFR. But this is a troublesome method. You have to have patient in the hospital or in the clinic. You have to administer inulin, which is a foreign substance, and then you have to measure blood levels, urine levels, so on. It takes time. Okay. So, but you know, we want shortcut, right? This is just to give you an idea that inulin, when it's passing through the glomerulus, it only gets filtered. Passing through the tubules, nothing happens to it. So whatever was filtered will appear in the urine. Creatinine is a byproduct of muscle metabolism, and it is also cleared entirely by glomerular filtration. We can use it to measure GFR. Okay. There is some very small amount of creatinine secretion and reabsorption, but it is negligible. So we can measure creatinine to determine GFR. Now, what would you need to do if you want to measure GFR using creatinine? You need to know, you need to have blood sample, measure creatinine level there. You need to collect urine samples over time and see how much creatinine is appearing in the urine, right? Again, this is troublesome. We want further shortcut, right? What is further shortcut? Further shortcut is that you can just measure the creatinine and you do eGFR, which is known as estimated GFR. Okay? In actual clinical practice, we only take one plasma sample. We measure the amount of creatinine in the blood. And there is a formula. You need to have patient's body weight. And then you can use the formula to calculate GFR. Okay? There are many formulas. Cockcroft-Gault formula is the one which is commonly used. And this is the formula. You need patient's age. You need patient's body weight. And you need patient's serum creatinine. That's all. The only laboratory measurement you need is serum creatinine level. You put in this formula and you will get eGFR. All right, so it's slightly different for males and females, and you will get an estimated GFR. All right, make sense? Now GFR is very important because based on GFR we can classify renal disease, and we will see that next week when we talk about chronic kidney disease and acute kidney injury. Based on GFR values you can classify the kidney disease is level 1, level 2, level 3, level 4. Okay, so this is eGFR. Make sense? This is something you'll come across in clinical practice very, very often.